neonatologist will stabilize the patient, doing the normal things that we do for advanced support. And then neurology comes in to try to help create the differential and use some techniques that can help us do that. Those are the MR images that I showed you here and yesterday, and also video EEG. Of greatest importance is managing the seizures that occur. Newborns will not manifest seizures clinically in all situations, and probably in most situations, and especially after we give them a drug called phenobarbital to stop any initial seizures. They will stop moving completely, but they can have status epilepticus on their EEG. This co-management model involves daily rounds, standardized guidelines, and I learned from the students at VHS that they are working on the WHO ICF paradigm to create protocols and guidelines for a number of different conditions. This is critical, standardizing your care. Communicating with the family, anticipating needs. I think we do this well, but we can do it better, and I certainly learned from our colleagues the other day how well we could get to do this. So we think co-management is an important model of care. You need resources available 24/7 to do this, though. You need to be able to call in the EEG tech, to have neurology come to the bedside and assess the patient. You need to be able to put that baby on a cooling blanket within 6 hours of life, and you need to be able to monitor them. So you develop protocols so that everybody is doing the same thing all the time. And when we do this, we ask the question, has the baby suffered brain injury? How is the brain adapting? Does the infant need us, the neurologists? And most importantly, is that baby who's lying still on that isolette having seizures? And here again, you see the massive equipment that's required to answer some of these questions. Video EEG is our gold standard. We have trained technicians and experienced readers like Dr. Chilio who guide us. The Amplitude Integrated EEG is a great bedside tool. It's cheap, it's easy to use. You can train the bedside nurses, techs, to put these on, and you can learn a lot. It won't tell you about every seizure that you see, but it'll tell you a lot about how the brain is reacting to what we're doing to the baby. We monitor any baby who has high risk for seizures. We were talking earlier about who is fragile. Well, certainly any preterm baby is fragile. And then any baby who has had any episode of hypoxia-ischemia, prolonged circulatory arrest, any sign of infection, stroke, hemorrhage, or cerebral edema that might be caused by an inborn error of metabolism. We look for paroxysmal events, but we don't often see them clinically, so we need the EEG. Sometimes we have to paralyze the babies because of pulmonary hypertension, and they have to be put on ECMO, so that really pushes us even further into monitoring them carefully. And we know that through these monitoring techniques, we can actually predict who's going to do better. And even something as simple as the Amplitude EEG can tell you whether that baby's going to do well. If that Amplitude Integrated EEG normalizes within 24 hours of birth, you're going to have a normal baby. That's great news and something that you can give to the parents. If they never achieve the cycling that we see that should be associated with a normal brain, then we know we're dealing with a baby that's going to be challenged and may have a poor outcome. And so we have to go on and do further testing. The characteristics of the EEG we've published, and we also see similar kinds of findings where the EEG can predict outcome, looking at epochs early during cooling. So in summary, I hope I've shared with you the concept that there are many ways to achieve neuroprotection. This is fabulous news for all of us and for our vulnerable children. Hypothermia is now standard of care in the United States for babies born with hypoxic-ischemic encephalopathy and throughout many countries. And I hope even in low-resource settings like the villages in your country that you'll be able to do something as simple as use ice packs to keep the babies cool and monitor them without high-tech equipment, just to preserve some of that precious brain. The best strategies that we will develop will have to target multiple mechanisms. So this is not going to be a simple and easy magic bullet answer to this problem, that we might be using hypothermia, we might use EPO late to induce repair, we might be using something in between to reduce inflammation in the brain, and if we know enough about the condition of the fetus, we might even be treating the mother long before the baby's even born. We can use advanced MR techniques, both fetally and in the newborn period. It can show us what the injury is at or near the time of birth, and it can also show us how well we're doing with our therapeutic strategies, as I showed you with the developing connectome. We think brain-focused care, which sounds so simple, is the way to go, that team management and co-management is the only way to accomplish brain-focused care, and we think that it isn't a hard concept to get out there, but we must continue to push this message as far as we can. There are many, many people at the University of California that contribute to my success for sure, and heading that list, and in alphabetical order, James Barkovich, who is, I consider, the father of pediatric neuroradiology, who has told us so much about how the brain has developed. You've met Dr. Cilio over these past couple of days, who has helped us with the epileptic encephalopathies and seizures, and a whole host of individuals over 2.5 decades that have worked diligently to try to figure out how the newborn brain is injured, how that injury differs from injury in the adult, and have struggled with me to find funding to research these questions. And we are thankful to the National Institute of Health of the United States, to the Howard Hughes Medical Institute, American Heart Association, March of Dimes, Fondation Leduc, and others that have contributed to these investigations. I thank you for your attention, and I'll be happy to entertain questions.
Thank you, Professor Ferriero, for not only an excellent lecture, but a very inspiring one. Please give her a very big hand. The T.S. Srinivasan orations are always interesting, but this one is a bit different. It came with a lot of hope and the possibility that there are things that we can do to make things better for our younger citizens. And I think the pioneering work that Professor Ferriero has talked about is really inspiring to all of us, something to look forward to. We have, as a tradition, questions, so the floor is open for questions from members of the audience. Would you like to sit down? Yes, please. Please come to the mic, introduce yourself, and ask your question. Of course, sir.
I'm Dr. Lango. My question is, during the resuscitation process, should we switch the warmer on or should we keep it off?
We have had a tendency to over-oxygenate and heat our babies. And I would say that you might want to, in a severely asphyxiated baby, keep the warmer off There are neonatologists in the room who can comment about that. But the key to salvaging that, I'm talking about the term newborn now, not a preterm baby, salvaging that brain is getting that brain cool quickly. And to heat the baby up only to try to cool it down immediately after you resuscitate is just, you're fighting against yourself. So keeping the using ambient temperature to help you. And of course here it's a little bit hotter, so you might want to start thinking about passive cooling.
So what is the lowest temperature you can achieve with hypothermia?
What is the lowest
temperature?
temperature? You shouldn't go below 33.5. So you need to monitor temperature carefully.
Professor, my name is Rajagopal. A family friend of ours had a grandchild born about 4 months ago. The baby was born with the brain half filled with water. We had a neurosurgeon in the same institute, Voluntary Health Services. The baby was rushed to that surgeon, and he said an immediate surgery must be performed. And if the baby would stand anesthesia, it will survive. He has already done about 15-20 surgeries. Now it's recuperating. I know it's a difficult question to ask because we've not seen the baby at the records. In such cases, what is the chance of survival of the baby, number one? Number two, normal functioning of the brain.
So much depends on what the etiology of that lesion is. So if you're describing a baby with half of a brain, you're thinking about a baby that has had a huge acquired injury sometime before birth in utero. Those babies will invariably have abnormal outcomes because even though it really does depend on when the injury occurs, but even though even if the injury is early in gestation, you're going to end up with some difficulty because not all of the ipsilateral connections can compensate for what is lost.
Chances of normalcy in brain future?
Chance
of a normal brain.
The brain isn't going to grow back into that space. And so you can learn a lot by looking at the baby now. So the baby has certain functions that you can map and monitor. And so that exam now will tell you about future prognosis.
Thank you.
I'm Neonatal. I'm doing a research work on the brain itself. My father had a paralytic attack when he was 86. Half his body was paralyzed. He became vegetable, totally a vegetable child. So 6 days doctors attended on him. On the 6th day, I took him to the bathroom, filled the bucket with hot water, moderately high, filled the bucket with filled the bucket with hot water with moderately high, and opened the cold water tap. Started pouring on his head. Meantime, I closed the hot water tap. Again started pouring on his head for nearly 20 minutes. What happened is, when the temperature fell down, when the temperature of water falls below, near to less than 20 centigrade, not more than that, 15 centigrade. So the body temperature fell down. Blood started rushing to the surface area to protect the skin. Actually, the blood that went to in the surface area has to, by the contraction of the
Can I
blood
ask you to ask your question, sir?
No, this is another thing. This is a very important thing. The blood rushes to the surface area to protect the skin. Meantime, the blood vessel contracted. He had an embolism in the blood vessel. That's the reason that he had blocked the entire brain from it happened to be a paralytic attack. So,
Thank you. Thank you.
Right then. You are,
Can I ask you for your comment?
one thing.
Okay.
Right then.
I think he's asking about use of cold water in adults as a way of
The
getting them better after
hypothermia treatments for adults are used. Out-of-hospital cardiac arrest successfully, hypothermia for stroke. Their studies are still ongoing. They are not as encouraging as those for cardiac arrest in or out of hospital. Cardiac arrest in children, hypothermia trials are also ongoing now.
Thank you.
Can you hear me?
Yes, ma'am. Please, we can't hear you very well.
Yeah. Now, 30 degrees Fahrenheit is 0,
No, 33.5 Celsius.
33. That's the, okay, right. Now, what about the skin? When you keep ice packs for the baby, how do you protect the skin from getting frostbites? And
So you wouldn't immerse the baby in freezing water, right? You would use a cooling blanket, or in low resource settings, people have used cold water bottles on the liver or the chest.
No,
There's always a chance that the skin will erode in those areas, and that was seen with the CoolCap trial. But you wouldn't immerse a baby.
yeah, no, you mentioned in villages, we could just keep ice packs, like probably in a polythene bag, and
Yeah, you have to rotate because there will be skin
now
erosion.
during normal delivery, we see like we are very fussy, switch off the air conditioner, and then cover the baby. And is it really essential to do that, or?
In normal deliveries, and the baby comes out normal and is active and has great APGAR scores, you should just continue doing what you're doing. But if you have a severely depressed baby, you want to get that baby cool as fast as possible. But you should do it with a protocol that you've developed in your hospital so that everybody's doing exactly the same thing and the baby is being accurately monitored.
No, my doubt was like you say you can create hypothermia for neuroprotection. Then why are we so particular that we should keep the baby like warm as soon as it's born?
Because we haven't advanced enough yet. Why do we give 100% oxygen for so many decades?
Yeah, thank you.
Thank you. Can I ask a question? With MRI, which is guiding your treatment of these early difficulties,
Yes.
and also is antenatal diagnosis a real possibility as we go forward? And also, do you conceptualize MRI-based treatments as well going forward?
Yes. So you should ask Dr. Suresh.
Who's here?
We should. We definitely will use more and more fetal MRI to diagnose difficulties, and we've been able to impact care, well-being, and outcome of babies. I think the best example is the MOMS trial, where we've treated babies for spina bifida fetally in intrauterine surgery with great outcomes. And maybe you might want to make a comment?
So there's a mic behind you.
I think fetal MRI in terms of neuro is a very important investigation. At present, we exclusively use it for when we identify a structural abnormality to see anything more than ultrasound which we can pick up. But what I would believe in the future will be functional MRI. If it comes in a big way in the fetus, then we would probably look. We are not in a position to identify cerebral palsy at this point in utero or predict that this baby would have cerebral palsy, though there is a small research that has gone on in Croatia where they have studied fetal behavioral patterns on 4-dimensional ultrasound to see whether baby is grimacing, smiling, and then they have correlated all these events to an immediate postnatal event. So there is some study going on at this point, and by which the professor, he thinks that we would be able to identify cerebral palsy in utero. But I think we are still far away from it on its universal application.
Can I ask one other question to both of you? The safety of repeated MRIs in mothers who have potentially difficult births ahead of them.
Yeah, I know of no indications against. I think you would never want to sedate a mother to try to sedate the baby to reduce movement, you wish the baby would stop moving, but a moving baby is a good baby. But no, there are no contraindications.
Yes, doctor.
Dr. Murugan, pediatric neurologist from Chennai. You rightly pointed out 56 babies needed to undergo hypothermic treatment to prevent one cerebral palsy. My question is, would it be cost effective to introduce that for India?
Yeah, so it's 6 to 7 babies need to be treated to reduce a morbid outcome. So the 56 number was for antenatal magnesium to reduce CP. So antenatal magnesium is probably not as cost effective, although it's a great tocolytic. But hypothermia can be done cheaply and wisely with good protocols, even passively. So I think it absolutely would be. And in fact, Nikki Robertson, the woman who did the experiments with the piglets that I showed you with hypothermia and melatonin, is doing a study here in India in a low resource setting to see how effective they are and to make sure it's safe.
Thanks.
We'll take one last question. Yes.
Ma'am, I would like to know, is there, I've even had, I came across certain evidences about male predominance in pediatric stroke. What would you tell about that as a comment?
Male predominance. I can't tell you why, but I can tell you it's true. There's a male predominance in the newborn period in neonatal stroke. There's male predominance for every type of stroke seen in childhood, and Heather Fullerton has looked at this. She's actually looked at, there was a theory that at least in childhood, boys are more active, more exposed to trauma, and trauma could be a risk factor for stroke. But even if she controlled for that, she still saw an increase. So we don't know.
Thank you. I would request Professor Srinivas to give the vote of thanks.
It's my pleasant duty to say the thanksgiving. First, I want all of you to give a standing oration to the Srinivasan family. And now a thanksgiving and oration to Donna Ferriero. I want to thank Mr. Lakshmanan, Director of the TVS Group, and Bala, who have consistently over the years helped us to organize this program and attended to all our phone calls. Only Bala now says I'm driving the car whenever we ring him, so that's a nice way of saying that ring me later. The other person that I'd like to thank is our own staff in the VHS and all our colleagues who have worked over the last 2 or 3 months continuously to make this program a success. I want to thank the staff of Marandishwara Enterprises who have run the workshop for the last 2 days very efficiently and nicely. And I also want to thank our own Grand Chola. This year we have shifted from Park Sheraton to Grand Chola. Every year we used to have this oration. They have responded to all our requests, and I'm very happy that this function has gone on so nicely. And of course, I wish to thank everyone else who has participated today, all the people who have come in and attended this meeting. And thank you very much. Thank you.
High tea is served. Please join us for high tea right behind.